can hear me well. First, I'd like to thank the organizers.
The mic doesn't seem to be on. It's quite hard to
Oh.
No, it's not. Oh, no, it is.
Oh, it's on.
Yeah, just check a little bit.
So maybe
Jeez.
I should just take it in my hand.
No, that's fine.
Is that good? Okay, so I can move around a little bit, so not too bad. Again, I'd like to thank the organizers and Amanda Aikilula for inviting me to this great conference, and I'd like to congratulate you all on a great success so far. So certainly I have nothing to disclose, but the fact that I'm dedicated to find out about the phylum and what's wrong with the phylum, and how phylum pathology can cause trouble, why can it cause trouble, and how it might be connected to also other systems in our body. Please go back. I might raise the finger. Is that okay? So then, because I'm nodding a lot. So basically, what we're talking about today is that thingy here, the filum terminale. The filum terminale is a structure that kind of emerges from the tip of the spinal cord with the conus and kind of anchors the cord to the hose, which is the dural thecal sac, and has some external extension, which is not well studied. From the embryological standpoint, the filum terminale was once embryonic spinal cord, and then went backwards, which is a process that's called retrogressive differentiation, where the spinal cord just disintegrates, dies off, so to speak, and turns into just like a fiber thread consisted of collagen, elastic fibers, maybe some vascular structures, and some dead spinal cord in there. As I said, from the embryological standpoint, it's probably not so surprising that a lot of things can go wrong with the phylum, because if that process is incomplete, the phylum can be too thick, too tight, abnormally structured, or abnormally elastic, and it wouldn't be surprising that this certainly can cause trouble. But physiologically, we still don't know what the phylum is for, why we even need it. Is it just an appendix, a leftover? It's supposed to kind of hold maybe the spinal cord in place and steady it. But remind you, and that's why I brought the other picture, our spinal cord is held by much more forceful structures in our spinal column, which are the nerves that exit at all vertebral levels, and there are also some what we call dentate ligaments. These are small collagen structures that connect the spinal cord to the dura, and those are more forceful. So basically, we still don't know what the phylum is for, but it's there. It's causing probably more trouble than we think, and it's been largely overlooked. So in my overview, I'd like to address a little bit the most recent findings on the triad, the symptoms that predict whether or whether or not you have tethered cord. And we did some retrospective and prospective analysis of, let's say, like the top 3 problems in tethered cord. I'd like to also talk about a little bit of nuances in the surgical management. We have to understand here, we are doing highly elective surgeries here with that phylum. It's a very minute structure. So there are nuances that we have to address in order to prevent complications by all means. I'd like to talk to also a little bit about the pathology of occult tethered cord, making the statement why probably the phylum is more of a troublemaker than we previously thought. And finally, some translational research where we can also learn from other species what is wrong in the phylum, and where other species can actually tell us how a problem, for example, a connective tissue problem, can make you prone of developing tethered cord syndrome. So we should not be forgetting that it was pediatric neurosurgery that pioneered the occult tethered cord syndrome. What do we mean by occult? I should probably spend a moment on it. It's all about the conus level. So I have brought up the MRI. Assuming that the phylum is abnormally structured from that embryological process that went wrong, there was always the assumption that that phylum is pulling on the spinal cord. So people were expecting to see on an image, which is the MRI up here, that the tip of the spinal cord is pulled down low. When, as an adult or even as a younger adult, your spinal cord should end somewhat at the upper lumbar level, which Dr. Henderson mentioned yesterday and Dr. Chopra. But if there is tethering or pulling, it's supposed to be stretched and maybe lower. But in decades ago, people were looking at children that had unexplained urodynamic problems like incontinence or bladder retention, and were identifying that those also might be tethered despite a pulled spinal cord, despite a low-lying conus, and that's how the term occult came along. That is tethered cord that is not seen on MRI, so radiographic negative tethered cord. And this is what it's all about. And my take-home message is that probably, that more tethered cords are radiographic negative than we think, and that's why it's been largely overlooked. So watch out for your tethered cord. Anyways, Dr. Henderson told me yesterday that actually it was Dr. Jerry Oakes from Children's of Alabama in Birmingham who first pioneered the occult tethered cord and advanced the knowledge about like transectioning this filum in children with urodynamic problems. The hallmark at that time was thought to be incontinence, bladder retention, and that justified the surgical intervention in these young children because no one wants to have a child that has permanent bladder damage. And then randomly, the first publications also kind of collected some other symptoms that were going on in these children. The pain, back pain, leg pain, some neurological findings that were also unexplained, some higher tone or lower tone, abnormal reflexes, some asymmetrical leg weakness, and then even in younger adults, spasticity, along with also orthopedic abnormalities, scoliosis, which probably was back then termed as idiopathic scoliosis, but yet it was probably the tethered cord, or skeletal abnormalities as foot and leg deformities. So, but never were these other symptoms associated with the bladder findings scrutinized in a very thorough way to see what are the unique symptoms in tethered cord and what might be the top 3 symptoms and what might be the symptoms that even predict surgical success. And that was that we were looking at. We started first to do retrospective analysis of the symptoms in our adult and pediatric population of occult tethered cord syndrome, where just to show you 60% of those had connective tissue disorder comorbidity, EDS comorbidity, and we looked at not only the surgical result of tethered cord resection or filum resection, but also the symptoms pre and post-op, and certainly also at the histology. So this is a busy slide, but that just should show you that we looked at all sorts of symptoms. We were not exclusive. So people were reporting also symptoms not only in the legs, but also in the head and in the upper extremities. And so we looked at all those and found some unique pattern and some major players here. Of course, in the urinary realm, it's not surprising that constipation and urinary incontinence were among the most frequent. You see here pre-op 112 patients. Meanwhile, there are more, and this is the number of patients that suffered from those. And then in the neurological, I termed it subjective, but it's not really subjective because as a doctor, if you listen, you see those things happening in a person. It's the lower extremity pain. The pain travels, but not like in a certain way that it always goes to the big toe. It's a patchy traveling pain, and one day in one leg and one day in the other leg, and at different spots. Not a surprise if we think it all comes from spinal cord pathology. You also see lower extremity weakness, but one thing I want to point out here in the subjective findings, what we discussed yesterday, also headaches and suboccipital pain and pressure is reported quite frequently in 40 or 60 of those patients. So up to half of the patients have also like pain at the base of the skull, and you wonder, and we discussed that briefly yesterday. Then the objective findings were mainly hyperreflexia and foot clonus. I still think this is a very reliable sign, whereas in the upper extremities you want to see like lesser brisk reflexes, so that probably has something to do with the spinal cord traction and tension, or abnormal dynamics in the spinal cord. And then the orthopedic findings were mainly pain. I subsumed orthopedic findings under pain. I hope Mike Healy agrees, because there is some, skeletal element and bony element or muscular element in the pain. So what you can also see real quickly here is we compared the improvement of those major findings pre and after 3 months post-surgery, and you see there's a lot of like 0.01 significance. So those are also the symptoms that mainly improve already after 3 months. So we kind of make the point, and actually also going to report that now in publication, that there is, like in each of the category of the triad, the urological, the orthopedic, and the neurological, a top 3. So for urological, it is probably the leaking and the incontinence. Would you mind advancing? So, and the constipation. For the orthopedic, it's back pain and foot and ankle deformities and the scoliosis. And for the neurological, probably the unique symptoms that we have to watch out for is lower extremity pain, weakness, and very important asymmetric findings. We shouldn't be dismissing tethered cord if you have symptoms going on in both legs equally, but the majority, probably more than 60% of the findings, lead to like that one leg is more affected than the other. And often when you really go deep into quizzing a person, they eventually say, yes, if I look back, it was my left leg that started to get weaker and I started to limp. And often that is a leg that also progresses once the symptoms progress. So based on that, we now have established a protocol for surgical decision-making and surgical intervention for occult tethered cord, which is based on the triad, Neuro, and Ortho, and those symptoms that I just displayed to you as the top 3 unique symptoms found in each of the category. And then only if people don't display all 3, we mandate that the urodynamic studies should be positive and indicating some neurogenic finding. But you should also not dismiss a patient that probably displays the full spectrum of the triad by equivocal findings in the urodynamic study. I know that this is probably more controversial, but yet you still have a syndrome that you have to trust. And then we include more comorbidities that you all know to understand how the tethered cord and the filum probably also affects other comorbidities. I have no word to say how it might affect dysautonomia, but we are looking into that. And certainly then, if symptoms progress over the course of 6 months, then we feel comfortable to offer surgical intervention, even in the absence of radiographic findings. If symptoms are kind of stable-ish and the quality of life is acceptable, we would just monitor for tethered cord. So before we go on to the surgical nuances, just 1 more minute on very exciting things. So, I told you it's all about the conus level. And things get dismissed if the MRI doesn't show the conus being low or something abnormal in that area where you suspect the filum to be. So we looked, I had 2 radiologists look at all the MRIs of the patients that had tethered cord surgery and that still had success from tethered cord surgery a year post-surgery, which is kind of the gold standard of surgical outcome, the 1-year mark. And and I had them to scrutinize the conus level. And you cannot just eyeball the conus level from a sagittal MRI and saying, oh yeah, the conus is kind of at the level of L2, and then say appropriate level. You have to really have dedicated high-resolution images where the cord is black and the spinal fluid is white, because then you can cross-reference the level of the conus to the level of the vertebra. So you go down and see this is still conus, and these are the little nerve roots. Once you go lower and this conus disappears and you only see the nerve roots, then you know that you're below the conus. And that by doing that, you can see, hopefully you can see, that here, the dark bar is the tethered cord patients, and the gray bar is the control. That both are in that, peak of the bell-shaped curve. So the L2 is probably like our gray zone, where you can have tethered cord or you cannot have tethered cord. So you can't just report your conus ends at L2. So you have to be a little bit more specific with that. But yet also maybe L2 is already too low for normal, and I don't want to use the term normal at all anymore. I'd like to abandon that, if possible, if ever possible. However, what got me really excited is, next slide, is that I convinced my radiologist, I don't owe them, but I told them, don't write on that report no evidence of tethered cord. Then this is a hard stop for anyone who's ever considering treating a person where you think that person is suffering from the filum and from the filopathology. So they are now all doing that one. They are doing conus at the level, and they do this cross-referencing, and then I allow them to say that there's no evidence of fatty or thickened filum, but still, I show you in a minute that that's not even necessary. Your filum can be a trouble maker without any abnormality in the MRI. But what was even more exciting was that Amanda Baker, the radiology resident, got this accepted in the American Society for Neuroradiology. So it made it in there as a talk in one of the main sessions, where she reported that there doesn't need to be radiographic evidence of low-lying conus. So I hadn't gotten that into any neurosurgical meeting, but at least it met the radiologist. So also, one thing I'd like to say real quickly, I know I have to be mindful of the time, but it could also be, so see, this is a boy who in 2016 had like a normal scan. In 2017, because he kept having problems and I didn't know what was going on, I rescanned him, and all of a sudden, this little white dot in the hose was fat. So fat can escape the imaging, and don't forget, the filum is moving with the spinal cord pulsation. It's wiggling. No MRI corrects for those movements. So it might even be that a lot of things in the filum escapes our imaging, so the MRI is not the biomarker. Next one. One word to the urodynamic study. Dr. Santos, our urologist and our team, found out that particularly in people with EDS, the truther sphincter dyssynergy, which is the mainstay of a urodynamic bladder, which when you go to the textbooks, that's what people demand, is probably not necessarily the own criteria of a neurogenic bladder in EDS. We should remind ourselves that the bladder is a connective tissue, and there might be some large capacity. So she also found that the same amount of patients have the truther underreactivity. So there's 40% with overactivity, 40% of the underreactivity, but both comprise a neurogenic problem in the bladder that's probably due to tethered cord. Next one. And then certainly what we like to see as like the standard of the proof that what we did was a good thing is improvement in the bladder study. This is a lady had underreactivity in the EMG pre-surgery, and then a big improvement a year post-surgery. So this is the evidence that we're doing something to change a bad nature or a bad player. Next one. The nuances in the surgical management. So I just told you that it's very important in these elective situations to refine the technique. And there are a couple of things that are still controversial, but I'd like to address. Does it matter where we resect the filum? Traditionally, people felt, well, we might not want to be too close to the spinal cord. So since the filum goes all the way down the spinal canal, we might also look at the red arrows, attack it low, and just to disconnect the spinal cord. But we think, if I say we, pediatric neurosurgeons have kind of pioneered that it's maybe a better idea to attack the filum a little closer to the spinal cord, to not leave too much filum behind. Because classically, it was always the fatty filum that kind of got reattached to the dura, because fat likes collagen. And so, and it's been shown in the pediatric world that the retethering stems from the fat getting attached to the dura. So you might as well translate that to all phylums, because maybe a phylum just wants to get reattached to the dura. So the concept is to attack the phylum closer to the cord. And this is just an example of a fatty phylum. On the left, you see the white line in the spinal canal here is a huge fatty phylum. Thank you. And when resected closer to the cord, you only have like a distal phylum left. And also it kind of naturally moves with the cord and is covered by the nerve fibers and probably doesn't get attached that much. That has not been scrutinized in prospective studies, and in all fairness, as a scientist, I just have to say that this is a nuance in the technique. Next one. This is not a video that should play, but this is a lady with occult tethered cord who came to me with question of retethering, and even an occult phylum. Oh, it plays. This is the nerve hook, and you see this is a phylum that was tethered, that was once detethered lower at the L4 level, and then I went higher at the L2 level, and you see the phylum actually, even a non-fatty phylum, was reattached to the dura, as evidenced here by the gentle pull, just to show that it retethers. Next slide, please. I told you at the beginning, it's very important to avoid complication, and certainly there is a chance of retethering from what I just told you. But I wonder, there are probably in these occult tethered cord situations where you are dealing with a minutely pathological phylum, but yet a bad player, tethering can probably also occur from a scar. And that, in my view, has to be really discussed thoroughly, because every intervention in the spinal fluid system can cause a scar and arachnoiditis, and that might cause probably tethering. So how can a scar occur? From a pseudomeningocele, from a dural leak, but then also through an opening of the dura, the nerve can protrude through, that is shown in here. And that certainly tethers the nerve, and that might cause the same trouble as a kind of tethered phylum. And certainly a scar in the nerves in arachnoiditis, where for whatever reason some autoimmune inflammatory process is happening that can clump the nerves, and then those nerves hurt. There's, as I said, some inflammation going on, but also tethering from the scar. So these need to be prevented, and the main important bad player in starting a scar is a CSF leak. And here I also learned my lesson with people with connective tissue disorder. We do, when we close the dura, what you see in the lower left, we close it like with a running suture, and then we ask the anesthesiologist to blow up the lungs. We call it the Valsalva maneuver, and then you see the dura expand, and then you don't want to see like spinal fluid coming through your closure holes. And that is usually something you trust. But with EDS, you shouldn't be trusting that. There is certainly things that can happen afterwards with the healing of the dura, probably. So I started to do autologous fat graft, which is some fat harvesting from the skin, which you can kind of cut in small pieces, and then with some glue, you put it, like with collagen glue, you put it on the dural closure, and that is had reduced the complication of CSF leak quite a bit, and is probably a good seal. And the surgery should be very clean, no blood, because blood spill into the nerves can also cause arachnoiditis. So that is kind of the thoroughness during the surgery, that it's clean, it's pristine, and then you can see after the phylum is resected, the nerves look all good, and with cottons and with some sponges you can avoid the blood from spilling in. The one thing I'd want to mention is the big elephant in the room is now, how do we assess a person after the tethered cord surgery, and how do we look at the MRI? Is there some MRI imaging that can potentially show us that nerves or some structures had gotten retethered, and the prone MRI is now certainly in discussion. And I'd like to go back one more time. I'd just like to show you you should be having an MRI after every tethered cord surgery, probably within the first year, because that's when a scar can happen. So one should not dismiss looking at the MRI. But here you see MRI post-surgery, and you see there is no arachnoiditis. The nerves are evenly distributed, look happy, so you could assume there is no retethering. But then another picture where it looks a little bit that the nerves might be attached to the dorsal aspect of the dura, and so here you wonder. And certainly in this patient, we now start to look at prone MRIs, where they're still very hazy, but if you look at the prone MRI here, down here, in this lady that I showed you the MRI before, you can see that the conus is probably a little bit, she's lying on her belly, a little bit too dorsally located to make, raising the concern. And in fact, she had the symptoms again. Her nerves, that's the surgical picture here, are a little bit attached to the dura through like small arachnoid threads. And the surgery had helped her, the second one. So, next one, please. These are a little bit of nuances. We don't know yet how we should go about the prone MRI, but I just don't want to throw that in the mix, because certainly we don't want to dismiss this concept of helping a person with tethering. Next one, please. So let's talk about the pathophysiology. Do I have 5 more minutes? Or yeah, okay. So I told you that the phylum stems from embryology, and that there can be all sorts of tissue in there from the dead embryonic spinal cord. So we did a lot of histological studies. The lower left shows you how a normal phylum should probably look like, with the collagen evenly woven and evenly distributed, just one pathway. And here you see like abnormal phyla from patients suffering from tethered cord, where you often see big vesicles, hypervascularity, more in people with connective tissue disorders than others. You sometimes see fat, the white stuff here, and then above the fat you see some purple dots. These are inflammatory cells. You do see ganglion cells, which are probably leftovers from the embryonic spinal cord. Sometimes you see even ependymal cells, which is the extension of the central canal of the spinal cord. These are ventricle cells, which indicate that this might be, in fact, an embryological problem, and is more the proof that you probably were born with an abnormal phylum. And then also, we see sometimes, I have to show that, nerves even. It's called nerve tricks running into the phylum, and this is the big question: what they do there, and we are looking into that right now. Next one. Most important, though, is the collagen in the phylum, particularly in people with connective tissue disorders, a problem, or is the collagen at all a problem in the phylum terminale? So if you go to the next, this slide is just showing you that also people without EDS can have occult tethered cord, and those there are slight differences. As I told you earlier, the people with EDS, there's a higher prevalence of abnormal vessels, dilated, bloated, congested vessels. How that ties into the connective tissue problem, I don't know yet, but this is a very interesting observation. But more important, the collagen. So we're looking at the collagen. And what we saw in these people with occult tethered cord is that often the collagen is disintegrated. It has like a cauliflower disintegration, as you can see there. It looks like it's dissipating. Normally a collagen in the cross section is a black dot, but you see also other dots that are really hazy. And then on the top picture you see like corkscrewing of the collagen fibers. You could say, well, is that maybe just an artifact from taking out the phylum, and you can kind of pull it, but it's not. It's definitely a phenomenon that we see and we don't see. So if that was the case, we would see it in all the phyla, but there are phylums with totally normal collagen. So people with EDS certainly have a higher prevalence of abnormal collagen. You can see here the green. and also a higher prevalence of abnormal elastic fibers, as you can see in the other one. But there seems to be a spectrum that probably occult phylum is a problem of the collagen as well. And that actually has been described not in live humans, but in the cadaver section of humans, where Fontes in 2006 had already indicated that maybe abnormal collagen is the problem in occult tethered cord. And here I think we are onto something that we have to look at. Let's skip to the last 3 slides. Hold on, go back 1 slide. I want to just mention that when you look at electron microscopy, there are 2 things that you see. You see the intimate relationship of the mast cells in the phylum with the collagen, and you wonder whether they reside there or whether they go there, maybe through that external phylum into the phylum, with whether the mast cell activation disorder probably also aggravates the mast cells in the phylum in people with EDS, and you see all that disintegrated collagen and the intimate relationship here. The same is with the nerves, where peripheral nerves, unmyelinated, are also intertwined with the collagen. And remind you, peripheral unmyelinated nerves are nerves that trigger pain, that are associated with pain sensation and also with stabilizing pain levels. So here the phylum might actually also be a trigger of pain, not by just pulling on the spinal cord, but just being there and having an abnormal connection between collagen and the nerves. And the last one is our translational research, where we also looking at these poor horses with a connective tissue problem. And Dr. Rashmir and Dr. McElroy worked together with me on that in their research program. And we also looked at the phylum of these horses and compared the healthy horses with connective tissue disorder horses. And you see the same thing, that the normal collagen in a horse without connective tissue disorder and all like abnormally, unevenly distributed EM collagen in the horses with the connective tissue disorders. Reminds us pretty much of what we see in the humans. This is certain examples from people with connective tissue disorders and tethered cord syndrome, where the collagen is probably a major player. I'd like to thank you here with one like bizarre picture of whatever that is, but it reminds me of the phylum that leaves us with a lot of questions. I'd like to make the statement here that it's probably not just traction and pulling of the spinal cord. It is probably also that somehow abnormal collagen, abnormal connection to still residing nerve fibers, and probably also inflammation through mast cells is making the phylum sick, and ultimately the person that suffers from tethered cord. Thank you.